Nursing and midwifery birth asphyxia. Nursing and midwifery birth asphyxia. Nursing and midwifery birth asphyxia. Types of asphyxia. Asphyxia livid or blue asphyxia or stage of cyanosis. Primarily due to respiratory failure with Abgascal formula 6. Most common cause is blockage of the airway. Asphyxia pallida or stage of Shuckle S4. This is due to combined respiratory and vasomotor failure with Abgascal. Serum ministry. Depending upon the Abgas scoring system, the score 0 ministry indicates severe depression. Nursing and midwifery birth asphyxia. Etiological factors cause. Approximately 90% of asphyxia events occur as a result of placental insufficiency due to antepartum and intrapartum factors. Postnatal factors account for the remaining. Antepartum factors, these include placental insufficiency due to pre-eclampsia, hypertension, anemia, diabetes mellitus, and postmaturity. Other factors includes antepartum hemorrhage, malpresentation or abnormal lie, multiple pregnancy, poor fetal growth. Nursing and midwifery birth asphyxia. Nursing and midwifery birth asphyxia. Nursing and midwifery birth asphyxia. Use anesthesia and narcotics to the mother. Birth trauma, increased intracranial pressure due to hemorrhage. Difficult deliveries in malpresentation. Instrumental of operation delivery. Aspiration causing obstruction of air passage. Circulatory collapse due to blood loss and shock. Preterm babies are more prone to birth asphyxia due to weak respiratory muscle. Poor pulmonary expansion, low alveolar surfeit, and inefficient respiratory center. Nursing and midwifery birth asphyxia. Nursing and midwifery birth asphyxia. Signs and symptoms. The baby does not breathe, but may make an attempt to breathe or aspa. The period of apnea is usually short, less than 30 seconds, cries vigorously. The color is blue. Muscle tone is good. Cord is pulsating strongly and feels firm. The heartbeat is strong, but rather slow. Abgas score is 4-6. Nursing and midwifery birth asphyxia. Management of mild asphyxia at maternity center. A baby of this type of asphyxia responds to treatment promptly. As soon as the baby's head is delivered, clear the airway, suck out the mucus from the nose with mucus extractor. When a baby is completely delivered, put it over the mother's abdomen and continue sucking out mucus. Clamp and cut the cord and separate the baby from mother. Abgas score is assessed in the manner in 1 minute. In the absence of any respiratory effort, resuscitation measures are commenced. Nursing and midwifery birth asphyxia. Nursing and midwifery birth asphyxia. Severe asphyxia. This is one of the neonatal emergencies, a serious condition in a newborn. The baby is lacking to and deeply shocked at birth. Signs of severe asphyxia. Slow, feeble heart rate. Baby not breathing later, shallow breathing with occasional gasps occurs. Poor muscle tone. Pale gray. Cord pulsates feebly and slow. Feels flabby if the cord pulsates below 100 and weak. Immediately. Nursing and midwifery birth asphyxia. Management in maternity center. Aims. To establish and maintain respiration as soon as possible. To clear the airway. Provision of 0-2. Prevention of condition from getting worse. This is one of the neonatal emergencies, and no time should be wasted, as this is a matter of life and death. This condition should never be allowed to be treated in maternity center unless mother comes in second stage. Nursing and midwifery birth asphyxia. In summary, we consider the following. Position. Baby's shoulders may be elevated on small towel, which cause slight extension of the head and straightens the trachea. Ventilation. Clear the airway. Insert a neonatal airway. External cardiac massage. Chest compression should be performed if the heart rate is less than 6100 B/m and falling in spite adequate ventilation. Nursing and midwifery birth asphyxia. Aims of resuscitation. Establish and maintain a clear airway by oxygenation. Ensure effective circulation. Correct acidosis. Prevent hypothermia, hypoglycemia, and hemorrhage. Team maintenance of temperature. Provision of radiant heat source. Dry the baby. Removing wet linen. Nursing and midwifery birth asphyxia. Establishment of open airway. Position the infant. Suction the mouth, nose, and in some instances the trachea in meconium stained liquor. If necessary, insert a T-tube to ensure open airway. The initiation of breathing. Tactile stimulation and initiate respirations. Positive pressure ventilation PPU using either bag and mask or bag and ET tube. C. Maintenance of circulation. Stimulate and maintain the blood circulate by chest compress. D. Drugs. Nursing and midwifery birth asphyxia. Prevention of asphyxia. Good antenatal care and early detection of predisposing factors. Screening mothers early and referring them to hospital. Health education to mothers about nutrition, prevention of infections. Early treatment of infections that would lead to placental insufficiency, e.g. syphilis. Examination of blood to show condition like rhesus incompatibility. Good intranatal care. Prevention of prolonged labor. Take proper observations during labor for the maternal and fetal. Nursing and midwifery birth asphyxia. Nursing and midwifery birth asphyxia. Intussusception. An intussusception is a medical condition in which a part of the intestine has invaginated or telescoped into another section of intestine. This can often result in an obstruction. The part that prolapses into the other is called the intussusceptum, and the part that receives it is called the intussuscipiens. Causes and risk factors. The causes of intussusception have not been clearly established and are very poorly understood. Nursing and midwifery birth asphyxia. Epidemiology. It is diagnosed most often in infancy and early childhood. Its incidence begins to rise at about 2 to 3 months of life, peaks at 4 to 9 months of age, and then gradually declines at around 18 months. Intussusception occurs more frequently in boys than in girls, with a ratio of approximately 3:1. In adults, intussusception represents the cause of approximately 1% of bowel obstructions and is frequently associated with neoplasm, malignant or otherwise. Nursing and midwifery birth asphyxia. Signs and symptoms. Early symptoms can include nausea, vomiting sometimes bile-stained green color, pulling legs to the chest area, intermittent moderate to severe cramping, abdominal pain, rectal bleeding, often with red currant jelly stool mixed with blood and mucus. Lethargy. Physical examination may reveal a sausage-shaped mass felt upon palpation of the abdomen. In children or those too young to communicate their symptoms verbally, they may cry. Nursing and midwifery birth asphyxia. 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 Observe infant's behavior as indicator of pain, may be irritable and varying, sensitive to handling or lethargic or unresponsive. Handle the infant gently. Explain cause of pain to parents and reassure them about purpose. Diagnostic tests and treatments. Administer analgesic as prescribed. Continually reassess condition because increased pain and bloody stools may indicate perforation. After reduction by hydrostatic enema, monitor vital signs and general condition, especially abdominal tenderness, bowel sounds, lethargy, and tolerance to fluids to watch recurrence. Nursing and midwifery birth asphyxia. Hirschsprung's disease / agangliotic megacolon. Hirschsprung disease is a congenital condition in which the rectum and sometimes part of the lower colon have failed to develop a normal nerve network. The affected portion does not expand or conduct the contents of the colon, which accumulate in end-to-end. The upper portion proximal to the defect. Causes. Before birth, a child's nerve cells normally grow along the intestines in the direction of the anus. With Hirschsprung disease, the nerve cells stop growing too soon. Why the nerve cells stop growing is unclear. Nursing and midwifery birth asphyxia. Symptoms and signs. Constipation or intestinal obstruction, usually appearing shortly after birth. Constipation in infants and children is common and usually comes and goes, but if your child has had ongoing constipation since birth, Hirschsprung disease may be the problem. Green or brown vomit. Explosive stools after a doctor inserts a finger into the rectum. Swelling of the abdomen. Lots of gas / flatulence. Bloody diarrhea. Nursing and midwifery birth asphyxia. Nursing and midwifery birth asphyxia. Management. Hirschsprung disease is treated with surgery called a pull-through procedure. The surgeon removes the segment of the large intestine lacking nerve cells and connects the healthy segment to the anus. Some children may need laxatives to treat ongoing constipation. Eating high-fiber foods can help reduce constipation and diarrhea. Fiber helps form stool, making bowel movements easier. High-fiber foods include whole grain breads, vegetables, and fruits. Infection. People with Hirschsprung disease can suffer from an infection of the intestines called enterocolitis before or after surgery. Antibiotics are usually nursing and midwifery birth asphyxia. Nursing and midwifery birth asphyxia. Nursing and midwifery birth asphyxia. Signs and symptoms. Babies with this condition usually present with vomiting. The vomiting is often described as non-bile stained and projectile vomiting. Some infants present with poor feeding. Weight loss. Dehydration also occurs, causing the baby to cry without having tears. Decrease. Urine. Constant hunger, belching, and colic are other possible signs as the baby is not Able to eat properly. The baby may pass mekunin but will not pass stool. Nursing and midwifery birth asphyxia. 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 Postoperative care. Keep the baby warm to prevent hypothermia. Closely observe the general condition of the child, incision site, vital signs. Feeding after 6 postoperatively glucose can be given to prevent hypoglycemia. The first feed to be given to the baby may be 5 ml of boiled water. Baby may then, 4 HRS postoperatively, be offered to breast for 1 minute 2 minutes. The baby will then be given a breastfeed 3 HRLY, gradually increasing the time allowed for feeding, and thus increase the amount of feed taken. Observe condition after feeding to check if absorption has. Nursing and midwifery birth asphyxia. A non-follicle is a type of abdominal wall defect in which the intestine, liver, and occasionally other organs remain outside of the abdomen in a sac, because of a defect in the development of the muscles of the abdominal wall. Causes. Some cases of omphalocal are believed to be due to an underlying genetic disorder, such as Edwards syndrome trisomy 18 or Paddow syndrome trisomy 13. Gastroschisis is a similar birth defect, but in gastroschisis the umbilical cord is not involved and the lesion is usually to the right of midline. HRSA. Nursing and midwifery birth asphyxia. Management. Resuscitate the baby like any other baby. Cover the area with sterile gauze soaked in normal saline. Position the baby in a proper way to avoid lying on the abdomen. Inform doctor. Baby will require surgical intervention. NGT for suctioning. Intravenous infusion. The doctor may decide to cover the area with a layer of skin. Ensure proper hygiene.